Welcome, everyone, to this year's CR Arthritis event at the Canadian Rheumatology Association and Arthritis Health Professions Association's annual meeting in Winnipeg. I'm Kelly Lenvoy, VP of Communications and Public Affairs at ACE, and it is my pleasure today to be welcoming Dr. Jillian Horton to our show. Dr. Horton, welcome.
Thank you so much for having me, Kelly.
Dr. Horton is truly a Renaissance woman. She is a medical educator, a musician, podcaster, and an award-winning author of We Are All Perfectly Fine, a memoir of love, medicine, and healing. She's completed a residency and a fellowship in internal medicine at the University of Toronto and has held the post of associate dean and associate chair of that department. And in Winnipeg at the annual meeting, Dr. Horton, you are going to be delivering a keynote lecture on critical frameworks for tackling our burnout crisis. So we're going to dive into that today. I think our audience will be, I think, very interested in learning from you some insights, because we've been hearing about this burnout crisis with healthcare providers, particularly during and after the pandemic. And I think a lot of patients have questions in their mind, what's going on and what does it mean for the delivery of their healthcare. So before we get into that, maybe you can just tell us a little bit about yourself and how you got started on this topic.
Well, thank you, Kelly. So, there's sort of a central story to my life, I think, that influenced why I became a physician, and then later on, surprisingly influenced why I became so interested in this issue of physician and healthcare worker burnout. I grew up with a sister who was profoundly disabled. My sister had a pediatric brain tumor, had surgery for that tumor that left her with life-altering disabilities, and she lived from that age of 6 until she was 52 when she passed away about 8 years ago. And the thing that really shaped me, Kelly, was watching through my entire childhood her interactions and my parents' interactions with the healthcare system. Some of those interactions were amazing. Those healthcare workers were compassionate and skilled and healing and did incredible things for her. And other times, those interactions were really damaging and harmful and traumatic and left a long shadow in our lives. And so even though I had these other things that you alluded to that I loved to do when I was young, I was a musician and I am a writer and always had this parallel track to my life, I couldn't not use what I had learned as a sibling. It was just a compulsion for me. I had to go into medicine and try to find a different way of practicing than some of those other things that we had seen and experienced as a family. But what was really interesting for me was several years into my medical practice, when I myself had been cycling in and out of professional burnout, as so many of us do, I began to ask some qualitatively different questions. So previously the questions had been, how could people behave this way toward patients? How could anybody yell at a little girl and her parents or behave in such an incompassionate way? The framing changed for me, and suddenly I became really interested in, what are we doing to people that might make them behave this way? How is it that people who start in a career, a healing profession, with the absolute best of intentions, can find themselves behaving in ways that would have been unimaginable to them previously? And when I really started to look at the issue from this perspective, the thing I kept coming back to was the way that we train people, the way that our system forces people to work, and some of the really toxic aspects of our medical system. And all of that existed long before the pandemic. The pandemic put it on steroids. So I always find it kind of ironic. I think that I sort of started my career in medicine as a bit of an interloper with kind of an axe to grind with the profession. And somehow the script has totally flipped, and I have become one of the voices for healthcare workers and those who, really don't want these things to happen, saying we have to find a way to rework our entire system so that this can't be one of the occupational injuries that people experience, this numbing out, these behavioral changes, the profound sequelae associated with burnout. And that's really key, because the well-being of patients, just like my sister and just like every patient who's part of your organization, is interdependent with the well-being of the people who look after them. And for me, that is the absolute key.
Hmm. That's interesting. I think from an arthritis patient perspective, um, when we talk about healthcare providers as members of their team, it's not just a GP, it's not just a rheumatologist. There are a lot of people on that team. When you're talking about uh, this burnout that's occurring, is that across all facets of the healthcare profession?
It really is. The area where I have the most expertise is in physician burnout, but
Mm,
certainly a lot of what we know about healthcare worker well-being. I mean, the situation of nurses is absolutely horrendous right now.
hmm
What they have been through in the pandemic, as we all know,
hmm
is just completely um, it- it's unacceptable, and it's just been so difficult to watch and bear witness to as well. But we know that there is something qualitative about the medical environment, that when we bring people into it, and we expose them to some of these dysfunctional environments, the moral injury associated with it, the kind of workloads, the loss of autonomy, but the high degree of responsibility, we know that that formula is one that leads people to experience burnout and distress. So for sure, we are seeing these patterns absolutely across the board. They are not unique to physicians.
In our work, certainly during the pandemic, another other fault lines that were exposed during the pandemic, if you will, um, were certainly focused around health disparities and health inequities.
Yes.
And ACE has spent a lot of time over the last 4 or 5 years trying to wrap our heads around this and help raise awareness and start advocating. And one of the some of the themes that have come out of that, and we've been conducting national surveys on different topics, and sort of through a subset analysis and lens, looking at different demographic groups, different patient populations, looking at sort of social determinants, and trying to find out what is happening to populations like BIPOC patients, Black, Indigenous, people of color. Are there disparities between men and women? What about the care, arthritis care that is received in the North as opposed to the more urban South? And I'm just wondering, when we talk about healthcare providers, and again, in our world, that can mean quite a number of different practitioners. Are we finding uh, disparities amongst groups as well? Like, are there special challenges that a woman has in the profession, a BIPOC person, somebody living in Northern Canada? And I guess I'm curious to see if there's a parallel there.
It's such a great question, and I think what you're the short answer to that question is yes. So, for example, I think if we just think of medicine as a microcosm of the same bigger macrocosm that we all live within, and all the same problems and challenges that affect every other social setting in which we exist, all of those things exist, and those same patterns can be seen in medicine. So for example, we do have lots of literature to show that women experience higher rates of burnout. We do have lots of literature to show that, for example, physicians and healthcare workers who are BIPOC experience a higher cognitive and emotional load associated with those identities. And
Mm,
what do I mean by that? I mean, they are more likely to experience microaggressions. They're more likely to experience abuse, harassment, discrimination in their work and training environments. And the way I like to frame those things for people, just to begin to understand the impact, because again, we have, this real machismo culture in medicine that's defined us for so long, where people say you got to have a thick skin, you got to be able to work these long hours. If someone calls you comments on your appearance or you being a woman, or etc etc, you just got to be tough and endure these things. It's just completely the wrong framework. I think we all recognize that that's no longer a contemporary view. And I think a great way to think about how these things can impact really people in any profession, but again, thinking of how we often talk about this in medicine, is added cognitive and emotional load. So for example, if we have, and just for simplicity, if we just imagine a man and a woman going about their clinical day, and they each begin their day wearing white coats with empty pockets, and they have a busy day, but every hour someone puts a rock in the pocket of the woman physician or the woman healthcare worker, whatever the role, representing a microaggression, a sexualized comment, a time when somebody doesn't speak to that woman but speaks to the man instead, as if they must be the person of authority, or they experience a macroaggression, whatever we want to call it. And then at the end of the day, we talk to both those people and we say, how's your energy? How was your day? The person with the pockets full of rocks may well say to us, I am exhausted. And the other person says, man, I don't feel so bad. It wasn't a bad day. And I think it's a great way to begin to illustrate for people just the concept of, we may work in the same work environment, but our individual characteristics mean that we have different experiences working in those work environments, that we do not move through those environments in the same way. So it can't simply be reduced to toughen up, be stronger. That does not explain, some of these differences, and some of the disparities in burnout rates that we see. Another study that I also find can be really helpful for framing for people, helping people who don't have a lot of insight into why experiences are so different. There was a great study done a few years ago in the UK looking at experiences of rude, dismissive, and aggressive behavior in the clinical environment. And that study found a number of things, but one of the most interesting findings is they found that younger clinicians experience those events about twice as often as older clinicians. So it's another great example for when people might say, well, the young generation of physicians, healthcare workers, they're not as tough as my generation. It's important for us to remember that, again, the way that we experience that environment, it's not just about our perception. We have different experiences in that environment related to these kinds of factors, age being another great example, because we all go from young to old at some point in our lives, hopefully. So really inviting people to think about, some of these characteristics that we know make life more challenging, create inequities, create uneven loads on people's shoulders, and how that can translate into higher risks of burnout. At the end of the day, we have limited cognitive and emotional resources. It's just that in medicine, we've always pretended that that was not the case.
mm, that's really interesting. And I think you talking about younger members of the profession, and can even go down to, residents and interns and medical students. I guess there's a very important message here for them. And maybe this is a good opening for us to maybe look, in sort of general terms, what some of these frameworks you're going to be talking to the rheumatologists about in Winnipeg for tackling the burnout crisis. What do they look like?
Yeah. Well, probably my favorite framework, Kelly, is the Stanford Professional Fulfillment Model. And this is
Mm,
a model put out by the Stanford Well MD Center. Stanford is one of the leading institutions in the world at the sort of the cutting edge of the physician and healthcare worker burnout and well-being dilemma or problem. And that model, we can sort of think of it as a way to begin to think more aspirationally. Because when we talk about burnout, that's a heavy conversation. It's dark, it gets overwhelming, people feel hopeless. We can be paralyzed by the sense of what are we going to do about this absolutely massive problem that's going to take us a generation to even begin to meaningfully move the dial on. So rather than endlessly getting caught up in that, I mean, we have to have that conversation. It's important, but we also have to find a way to be hopeful. And we also have to sort of be casting our eyes up out of from the bottom of the well and thinking, what do we want this to look like? What do we want it to feel like to do what we do? What do you want your doctor, your nurse, your healthcare professional to feel like when they are doing the job that they're tasked with doing? And so the Stanford professional fulfillment model allows us to think about not just burnout, but what we want it to feel like to work where we work. And that model tells us, in a sense, that fulfillment is sort of the aspirational opposite of burnout. It's the other end of the spectrum. Some people say it's flourishing, but I like fulfillment because that feels true to me. That feels like on my best days as a clinician, what I have experienced. It's deep, it's profound, it's aligned with my sense of meaning and purpose. And it's really, when you feel it, you know it. There's nothing like it. So, in order to experience professional fulfillment, that model tells us that we need three things. And the first thing that we need in medicine is a culture of wellness. The second thing we need is efficiency of practice. And then the third thing we need, and it's a much smaller piece of this puzzle, is personal resilience. And this is one of the interesting problems because so often our conversations about healthcare worker wellness begin with resilience. People say, we're going to give you resilience training, we're going to do mindfulness training. And, I believe in mindfulness. Mindfulness has had a profoundly important impact on my life, but it's not a panacea. It's not the end of this conversation. In fact, it's a personal thing. That's why we call it personal, the personal resilience sphere, because if we want to engage in individual interventions, that should be up to us. The organization shouldn't be telling me to improve my personal resilience in lieu of addressing the things that the organization has jurisdiction over. So those two other things are really key. What's a culture of wellness? That's a culture where leadership is healthy. Leadership is emotionally intelligent. Leadership is able to know what motivates people, communicate with them effectively, and really lead in a transformative way. Mission and purpose, a sense of mission alignment, meaning, in a sense that our personal values are aligned with the work that we're doing as part of a culture of wellness. Diversity, equity, inclusion, but also belonging. We can have all the EDI policies in the world that we want, but if the people who are encompassed in that EDI umbrella term don't feel that they belong in those environments, aren't really meaningful to them, then nobody has EDI, and that's part of a culture of wellness. There are other things, meaning and recognition and appreciation. So feeling that you are recognized and appreciated in a way that's aligned with your own values. I've written a piece about this. I popularized this term called muffin rage. This was in the LA Times a couple of years ago, and I was really surprised that this caught on. Muffin rage is, what we feel when we go to a wellness event as healthcare workers and someone says, it's Staff Appreciation Day, here's your muffin. And you feel rage because you think, I don't need a muffin. I need sleep. I need a physically and psychologically safe work environment. I need some sense that this organization knows that I am working my guts out. I have nothing left to give, et cetera, et cetera. And so often, we use these surrogate tokens that are actually offensive to people for this reason, because they make them feel unknown. So those are some of the pieces of the culture of wellness. But this other piece, efficiency of practice, it's so key. And it's where organizations often fail to focus their efforts because it's so hard. So efficiency of practice, you've seen that as a patient. You go in and your doctor's bandwidth or your nurse's bandwidth is so preoccupied with, remembering their password because they've got to log into 4 different electronic medical records, or finding where they're going to enter your data or your last clinic note, or how to get the pharmacy to the prescription because prescription to the pharmacy, because a new tool has been rolled out and they haven't adequately been trained in that. So all that power of their neurons, that we want to be going towards you, the person in front of you. Instead, it's going into this electronic medical record or trying to get you booked to see a colleague, the inefficiencies there, the pointless, soul destroying work. Sometimes in this field, it's called the pebbles in the shoes, the things that, cause death by 1,000 cuts, that each day they recur over and over as these small injuries that eventually wear people out. So there are a number of other components to efficiency of practice, including prioritizing relationships. And this is another thing, that we've all experienced as a patient. Maybe your doctor, your family doctor, if you're lucky enough to even have one, maybe they've never met your specialist. Maybe there's no opportunity for those people to know one another as humans. And we know that when relationality is prioritized in healthcare environments, care is better. And it feels better for us as people delivering care as opposed to interacting with our phones and text programs and that kind of thing. So all of these pieces, and there's a lot more that I'm going to talk about to the assembly, but these are all things that constitute the requirements for professional fulfillment. And I often compare it to baking a loaf of bread. You can have your flour, you can have your water, but if you don't have your yeast or your salt or your sugar, you have 4 to 5 ingredients, you bake your bread, you take a bite into it, it's hard as a rock, and you go, why? What's wrong? What's wrong with this loaf? It's very simple. You need all the ingredients. And right now in healthcare, most environments, not only do they not have all the ingredients, many of them have like one ingredient, and that ingredient is just a person with ideals and altruism who continues to show up, but there's nothing else rising up to meet them.
Yeah. Take a deep breath after that. I think when you're in Winnipeg and you deliver your keynote and then start meeting people in the corridors or the side meetings, what really strikes, I think, a chord with me and our audience, and it's something that as a leading advocate in Canada, ACE is calling for, is this notion around expanding the role of arthritis health professionals.
Mhm.
So we've been spending a lot of time over the last 20 years talking about gaps in models of care. And one of the ways that we can actually effectively fill these gaps is to expand the role. And when we talk about arthritis health professionals, we're referring to physiotherapists,
Yes.
occupational therapists, registered nurses, nurse practitioners, all members of that team that we were talking about, to allow that clinic to run more efficiently and for that
Yeah.
rheumatologist to have better time served with their
Yes.
patient. And I think, I'm not sure if there's studies, but in terms of fulfillment, to use your words, I think
Mhm.
increased fulfillment. And I think
Yes.
on the part of the patient as well. So it seems to me there's alignment there that you're going to hear people talk to you probably about that,
Yes.
because I think it fits into your framework really, really neatly.
Absolutely. And I think there's a reason that we're hearing so much in this last 18 months, 24 months about team-based care,
Absolutely.
and the need for us to move in that direction. There are lots of reasons why it's difficult for us to change the way that care is delivered. I mean, just like in any professional setting, any business, any organization, when change is rolled out, there's learning anxiety, there's change anxiety, there's survival anxiety that goes along with that, and a lot of classic responses. And sometimes I think we see those things accentuated in medicine for reasons that if we had even more time, we could talk a bit about. I wanted to share one interesting observation that's been
Sure.
reflected back at me about these models, and because I have the opportunity to do a lot of work with organizations across the country and speak to different groups. We talk a lot lot about physicians practicing at the top of their licensure in the way that you just described. That's really important. You want your arthritis expert, your physician expert to be doing exactly the thing that they are the best qualified person to do. But one thing that we often don't hear about, so we call that practicing at the top of licensure. But one thing that sometimes allied healthcare professionals have said to me is, we hear a lot about other people practicing at the top of their licensure. What stresses me out, I am practicing way beyond the top of my licensure.
Mhm.
And this is another thing I think we sometimes make too simple. We sort of create a narrative where the idea is that all these other professions want bigger rules. And believe me, in many cases, they should have much bigger rules. I mean, we should be practicing not in this hierarchical way that we have historically practiced so often when we work in medical teams, but in really a much more holistic way where everyone has a role that they play. That is my belief. That's the way I've always carried myself working in teams, and I'm privileged right now. The clinical work that I do, I work with she's about to change roles, but an occupational therapist who really, we are absolutely a team. It's not me at the top and that person beneath me. I mean, we are side by side, just doing different things together, and it's transformative when you get to care for people that way. But I would just flag, I do think it is a risk sometimes that we don't always consider the other side of that, and this is where we really need to listen carefully to our allied healthcare colleagues to make sure that we never put them in positions where they feel that they are consistently practicing beyond the top of their licensure, going beyond what they actually want to be doing and feel that they are the best person to be doing either, because then we just create a whole different problem. We run the risk of burning them out in other ways. So just to flag that as something that I think we probably should be talking about even more right now, because it is something I worry about and I've seen happening to allied healthcare colleagues, and I don't want them just to be facing burnout for other reasons. 5 or 10 years from now, we really have to go about this as thoughtfully as we can.
That's that's a great way, maybe, to end our time together today. That has been a really fascinating talk. I think a lot of people are going to enjoy the keynote, and I'll be really curious to see what kind of conversations it generates and motivates over the course of the week in Winnipeg. Something I think that a lot of people in the room are going to want to explore. And let's not forget to the role of the patient here, and that is, I think, for our audience to learn a little bit more about what that reality is like for the person that's giving them their care.
Hmm.
And sort of a mutual empathy is probably what we're striving to, and being able to have a really good, honest, constructive conversation every time we go to see our healthcare provider in the clinic. So thank you so much for your time today. I'll be
Thank you.
really curious to hear again what that experience is like, Dr. Horton, and I'm hoping that we'll get a chance to speak again sometime soon
Oh,
as we
thank you.
follow your work, and maybe just follow up on maybe some of the feedback that you received
Yeah.
from the people in
Oh,
Winnipeg.
thank you so much. Well, it really is a pleasure to talk to you, Kelly. And I just want to say again, our well-being is interdependent, and I think the more we acknowledge that, the more we look at ways that we can help and support each other, and really no longer just see this as an individual problem of the healthcare system, but a problem that needs everyone to come together to address and solve, we will all be better off for that. There's never a moment when I would advocate for less empathy. And I think the work of patients and patient advocacy groups and support groups is so important. And I'm so grateful to you for bringing the patient voice in the way that you do.
Thank you. And thank you to our audience for joining us today for See Arthritis. And we look forward to seeing you again with another report from Winnipeg. Bye bye.